Good morning, good afternoon, good evening, wherever you may be. My name is Olive Kokeman for the Network for Improving Quality of Care for Maternal, Newborn, Child and Adolescent Health. As the participants are joining, I'll do a short introduction. Today, you're very welcome to our webinar, Engaging the Private Sector for Quality Maternal and Newborn Health Services, sharing lessons from Ghana. And so today, we will have presentations from Dr. Ernest Asidou, from Head of the Quality Improvement Unit, the Policy Planning, Monitoring, Evaluation Division, the Ministry of Health, Ghana. And Ernest will be accompanied by Dr. Isabella Sagomoses, the Deputy Director of the Family Health Division and Reproductive and Child Health, Ghana Health Service, as well as Dr. Paddy Ayerti from Alimis Health in the private sector in Ghana. And together they're going to share their experiences of quality improvement work, engaging the private sector in quality improvement for maternal newborn health. And so the facilitators today are Dr. Berta Malici from WHO Geneva and Dr. Rosalind Doe from WHO Country Office in Ghana. And I'm going to hand straight over to Berta, who's going to introduce the project, and then we'll hear from the colleagues from the ministry. Over to you, Berta.
Thank you very much, Olive. Good morning, good afternoon, good evening. In today's seminar, we'd like to share with you the experience that Ghana Ministry of Health, Ghana Health Services Ministry of Health developed in terms of engaging private sector for improving quality of care for maternal, newborn, and child health. This is a very important project that WHO has supported over the past 2 years for the sheer reason that private sector is playing an increasing role in delivering health services, maternal, newborn, and child health, but not only. So for WHO, we did have 3 main objectives as we engage in this work. First, we wanted to analyze and to understand what are the drivers and the current engagement of the private sector in delivering quality services, identifying opportunities for involving private sector in working with the national health system to deliver quality care, and finally, propose models for effective engagement. It is very important to underline that this testing and implementation that Ghana, along with Nigeria and Bangladesh, have done in the last 2 years is serving to WHO as a pathfinder for engaging with other countries. Next slide, please. As I already said, our private sector is playing an increasing role in delivering care. Looking at the SDGs and the deadline of 2030, with the goal of achieving universal health coverage, it is almost impossible to discuss achieving and reaching everyone if we do not talk about private sector. Some of the numbers that you can see in the screen indicate what is the role of private sector in delivering primary care. By now, we know that in some regions of the world, such as that of Eastern Mediterranean region of WHO, most of the services and first access is provided by private providers. Therefore, it is impossible now to discuss the achievement of universal health coverage without discussing the achievement and the engagement of a private sector in delivering care. Next slide, please. This is true for maternal and newborn and child health. In our initial literature review, we identified some of the critical numbers in terms of first point of contact or using services in private sector. 2 of the numbers that we'd like to share with you are that antenatal care in most of the private sector accounts for a mean market of 44% of use, while delivery of care, it is a mean market of 40%. It's obvious that for some countries, this may be very, very low, but for many other countries, this figure can be even higher. Next, please. Looking at the future, WHO has developed the strategy for engaging private sector to delivering services. This strategy was launched in 2020, and it is based on what we call the 6 governance behaviors. Next slide, please. So it looks at how can we engage, so how private sector can be engaged through governance aspects to ensure that it provides good quality care, but also plays its role in terms of the implementation. And those 6 governance behaviors are building understanding, foster relationship, enabling stakeholders, aligning structures, nurturing trust, and delivering strategy. So while this strategy from WHO was delivered in 2020, we in MCA, in maternal, newborn, and child health, started this work and the engagement with the 3 countries much earlier before, so since 2019. Therefore, we had to adjust the implementation as we were going through the new behaviors. Can you go to the next slide, please? So more in details, the way how we started and how designed the work that Ghana and the other 2 countries have implemented was basically looking at the outcome. which was enhancing private sector engagement to deliver quality of care for maternal and newborn health. For that, we looked at two-pronged approach, one from a country implementation, and the other it was to support the country implementation, or what you see there as a global level. So for the country implementation, all the three countries that have undertaken a policy dialogue that has led to they have undertaken situation analysis that has fed into a policy dialogue that has led to the recommendations which are aiming towards that higher outcome. One part that was very important was the values that each country adopted, and that was that the Ministry of Health and the government was at the leadership and on the process, that there was a full stakeholder engagement, special with private sector, and that there was a collaboration across different and similar private sector engagement efforts that either had taken place or were taking place forward. The work was guided, overall was guided by a technical working group composed of partners, scientists, and implementers, including the three member countries that led the implementation of this work. So with this frame in mind, next slide, please. I would like now to hand over to our colleagues in Ghana, to Dr. Ernest Asiedu, who has been the leader and the owner, I would say, of this process in Ghana, whom we would like really to thank for his leadership and guidance, not only for Ghana, but for the other countries as well. Dr. Isabella Sagomoses, who generously has opened maternal and newborn health as a pathfinder for this work, and Dr. Paddy Ayerte, who is the person who's representing the private sector in this discussion in today's presentation. With this, I would like to hand over to Dr. Ernest Asiedu, and I'll be in standby for the further facilitation. Thank you.
Thank you very much, Bleta, for the introduction and then also putting us in perspective, Sally, as far as the work is concerned. So like you mentioned, this work has been done. We had a local consultant. I just want to recognize Dr. Elom Ochi. He's done a good job, with us. Also, I want to recognize the head of private sector within the ministry. Currently, the name is called the Domestic and Bilateral Resource Mobilization, which is also located within the Policy Planning, Monitoring, and Evaluation. And also want to thank the entire leadership of the ministry, from the Honorable Minister, the Chief Director of the ministry, and then the directors, especially the Director of Policy Planning, Monitoring, and Evaluation, Dr. Emmanuel Odame, who has also given us the opportunity and guided us in allowing this work to happen. So I'll be talking on the process, but also, as you have already mentioned, the three of us will be doing this presentation on behalf of Ghana. We've taken a lot of support from our colleagues, some on the platform, others are yet to join. And so myself, Dr. Isabella Sagomoses, and then Dr. Paddy Ayerte, I think I usually would say that as far as the adolescent health is concerned, there's nothing about me without me, for me, nothing for me about me, with me without me. And so we cannot do a presentation for the private sector when the private sector is not duly acknowledged and involved. And so that's a very important part of it, where Dr. Paddy Ayerte joining us and also speaking and on behalf of the private sector. Of course, we know that the private sector is very wide, and then during this presentation, some of the interesting things will come up. So I think Dr. Paddy joined us just at the time that we were starting. So on the screen, I'm sure you can see. So when he comes on, we'll do also introduce him again. So I'll quickly go on to the following what Bleta has said, which basically alerts us that this is not something we are doing only in Ghana, but the work that we have been almost 5 years now, we noticed it was a little bit more skewed in the direction of the public sector. And so we need a bit more deliberate. And Ghana, also is very happy part of this study, joining Bangladesh and Nigeria, to be able to have a better understanding, to gather some lessons, something that is worth sharing, like a change package. We really want to reach far as far as maternal and newborn care is concerned. And then with the UHC leaving no one behind, we know certainly that we cannot achieve our sustainable development goals if private sector, which plays a very important role, is left out in Ghana. So this has been, I would say, a very big eye-opener in what we are going to do. So the process, as we see in developing our situation analysis, and then ultimately end the policy dialogue that shaped what we did. We looked at it as between November 2019 and June 2021. I must say that initially that finished a bit quicker, but of course, in the whole of 2020, we had a different ball game altogether as far as the entire world is concerned. So we were able to establish technical working under the leadership of the Ministry of Health, and we agreed and looked at the scope based on initial presentation that Bleta also did. We developed an internal research protocol, applied for clearance, and we take our approval. The Ghana Health Ethical Review Committee of the Research Division, Development Division of Ghana Health Service. Then the situational analysis was done in the way that we did some kind of desk review, especially gathering all the kind of literature review, gathering all the various policies, guidelines, documents that were already existing to be able to have a better understanding of how the private sector and the various guidelines within the entire health, within the health system, that's the way service is being provided in the country. We did a key informant interview, and then we drafted the situational analysis, and then we synthesized it for the initial findings. There were great opportunities for us to do some back and forth, to be able to firm it up well with some kind of discussions and the ministry. And then we prepared for what we call the multi-stakeholder policy dialogue, which brought a lot of the other partners within the health space together to look into it, to validate this write-up or this document, to see whether it really reflects the challenges and the recommendations that we're going to come out of that. So during that, yes, of course, we did our validation. We discussed the various priorities around the key challenges and then came up with some specific recommendations that were going to be helpful for us to improve this engagement. And ultimately, we did our documentation and then a case study from there. And then we're going to publish this in a peer review journal. And this is where we are now as part of the dissemination that we're going to have. Next slide, please. So we'll quickly move on to the findings, and we are looking at the mother, a safe mother, a healthy mother, and then the live baby. Next slide, please. So some of the findings that we got. So a bit of the overview of the role of the private sector in terms of the size, availability of inputs and all that. I would say that the private sector delivers between 38 and 50% of services within the country, and it continues to grow. And this encompasses both outpatient and inpatient care, and even home-based care as part of the CHIPS policy within the country. So the private sector plays a very critical role. The faith-based, and I would say that in Ghana, we categorize them into the faith-based, which we call the NGOs within the service delivery space. We also have the self-financing that really, takes care of everything, private sector. And then there were other private sector, providing this kind of service as well. But we focus on, as far as the service delivery is concerned, these were the two major ones. Of course, we also within the country have what we call the Ghana Association of Quasi-Health Institutions. They also are public institutions. However, they do not directly belong to the Ministry of Health, and they belong to other ministries outside of the health sector. And sometimes in terms of the gap between the real public sector ministry facilities, they were also adopted and looked at and to give us some feedback as far as the relationship is concerned. So I'll be referencing the faith-based, which is basically not self-financing, and then I'll also be looking at the pure private sector, which is more self-financing, on that angle. And then some comparisons and some interesting things are going to come out of that. So in terms of the distribution, there is some data on the distribution, the size and the services of the private sector. And currently work is also ongoing to collect more data. We have our various regulators, especially for the Health Facility Regulatory Agency that has the mandate to license and regulate all health institutions within the country, both public and private, and they continuously work towards ensuring that as we license all the facilities, they would get onto their the database, and so we will have that opportunity to know in terms of the numbers, the size, the type of services that they provide, including maternal and newborn services, whether they are just the basic antenatal and child welfare clinic type, or they are very sophisticated NICU or high dependency units, and then also intensive care unit services. And we're going to look into some of these details and how the private sector plays this role and the challenges that may prevent them from doing such within these. So as far as input, we're looking at the various policies, the guidelines, the regulation, the leadership, and the governance related issues. And I'll say that multiple government policies and an extensive regulation, but the challenge has always been which may have challenges related to, like we continue to say, these government policies are very available. Then sometimes the challenges have been with the way we enforce and implement them, which sometimes there may be some duplications and things around that. But if you look at the faith-based institutions, which the Christian Health Association of Ghana basically is the biggest, but we also have the Ahmadiyya Muslim Health Service, which is also there. They have 7 hospitals within the country. And when you look at them, their governance structures are, in terms of they are well organized, whereas when you come to the self-financing, it's a bit more fragmented because they are different levels. Some of them are, within the urban and the rural areas. And when we look into the various recommendations, these are opportunities to see how we can harmonize our efforts to get quality care within the country. Next slide, please. So for maternal and newborn service delivery, in terms of the outputs, in terms of the outcomes and the impact used on obedience, the process is concerned, the overall quality of maternal newborn health services in the country, we say that yes, generally across both sides, we say about not so good the services, since poor quality service exists both in the public and the private. The quality within the private sector was perceived more person-centered because, again, putting everything on the side, especially for the self-financing, you would really need the patient to be able to even take care of your expenditure. So on that side, it was a bit more they were a bit more persons, and the experiences of patients were much better compared to public sector. The faith-based seconded staff from the government because they were the initial memorandum of understanding that was signed between the faith-based institutions and the public sector Ministry of Health was their location within the rural setting to reach areas that the government could not necessarily penetrate. They were able to establish their health facilities there. The memorandum of understanding was such that the government was able to give them the staff and pay for the staff time, whilst they also manage the institution and provide service. In health institutions, yes, some aspects where some engagements like that have started coming up, especially for areas around antenatal clinic and then also child welfare clinic. But then there's limited specialized staff that resort to some kind of task shifting. And then also they may have some less specialized staff who may be providing some kind of services that basically are supposed to be other specialized staff work. In terms of accountability, we noticed that the faith-based organizations were more accountable to quality standards and have significant ownership and participation. Typically, a number of the faith-based institutions ultimately end up as that hospital or the primary facility within a particular. So we also tell some of the district hospitals and a little bit more better aligned to the public systems. But most of the private into the DHIs too, with support from the district health authority. We continue to expand these services to build capacity within the private sector to be able to also upload their data onto the national database. In terms of the market conditions that there's poor investment climate. I think that we're basically, as some challenges we'll still be looking at. But in incentives to deliver some level of care, especially very high sophisticated things like having a neonatal intensive care unit, which was a little bit more expensive, and then also the challenges of that kind of an enabling environment for the private sector to thrive in that sense has been a bit of a challenge. But you also notice that purely the self-financing operate largely within settings because they also maybe just say that they need to be able to continuously finance whatever service they provide, whilst the faith institutions were more located within the rural setting, especially for that at least able to support them with staff and equipment, and sometimes and things like that. So when we look at the relationship between the private and public sector, you would see that the faith-based organization closely with the Ministry of Health and the rest of the public institutions because of the special relationship and location of their facilities where the government should have been. And so that relationship is quite strong. And you can see that there's great opportunity for them to engage on both sides. The other one is that there's a little bit more challenge on the other side for the self-financing. That engagement is a bit limited. Next slide, please. So the initial recommendations from the situation analysis, again, one, we were saying that self-financing private sector needs to better organize and advocate for itself. And so if they're able to mobilize themselves well, they're able to come together, that may be a way for them to push and advocate for itself. The private sector has certain human resources and skills that can also contract and use. So there's going to be that bilateral relationship in terms of some higher level services. There would be that opportunity, back referral and also forward referral. There have been instances where facilities, could even, the public institution could refer to a private hospital and things like that. So that engagement is something which is great. The Ministry of Health needs to build a private engagement strategy and then also the capacity and develop clear roles as far as the governance structure is concerned. We know for sure that we can't be successful, we can't do everything, leave the private sector behind. So we need to be a bit more to structure things that ultimately will make everyone be comfortable and then also be able to reach where we intend to reach. There's a need to increase opportunity for mechanisms of financing and resources for the private sector while also setting up the relevant quality accountability framework. I think I've mentioned a little bit in terms of how we can support the private sector as far as, let's say, acquisition of loans and then also resources that are brought to their doorstep. They have to do importation, tax waivers, because the service is also going to be provided to the same people in Ghana. So these are that we are also looking at. And the immediate opportunities for improving quality maternal and new services, including harmonizing structures, strengthening the case referral, and improving our data share, reporting and analysis. I think these are opportunities for both the public and the private to work closely. And then establish mechanisms for regular public-private dialogue. I think the domestic and bilateral resource mobilization units of the Ministry of Health, as far as the PPM is concerned, are putting together this and working closely to ensure that at least this dialogue restarts it this year. Next slide, please. So the recommendations that I will be talking about, next slide. Generally, I would say that we identified about 9 challenges and developed some 14 corresponding recommendations that will address, issues around the communication and the capacity building for the private sector. I think one of the things that also came up was even at the time of engagement, the private sector, patients do come to them directly because they need to see some specific people who probably are the ones that are managing the institution. And so some engagements that happen during the day may be a bit of a challenge for the private sector to fully participate. And so that, as far as the engagement is concerned, we align ourselves to that. Legislative instruments for the private sector mandates, opportunities for us to look into all these. Revision of the health insurance tariffs for the private sector, since they really finance themselves. That's also one thing that we looked at. Alignment of the structures, and then stakeholder engagement, revitalizing the private sector alliance of Ghana. That will help us to also foster a better relationship, and then to be able to pull together the fragments and have one common voice that the ministry can really engage and work through. Next slide, please. So there were three major thematic areas as far as those recommendations were concerned, and I'll just run through them quickly. The first one is that establishment of service delivery in the country. The public sector is sitting on top of an act of parliament, that's the 525. And there's call that, yes, we need to do some kind of revision of this, of the Act 25 in terms of the process that should be based on broad stakeholder engagement. That would also bring the private sector on board and pass legislative instruments for all aspects, as per after the amendment, so that it will really bring some kind of better relationship to foster that partnership between the public sector and the private sector. Again, we also looked at the private sector policy that is guiding, framework that is guiding the relationship here. Yes, it was done, I think, 2013, and we have had some conversations around it during the multi-stakeholder conversation to say that, yes, it really needs to be reviewed, and then to be able to expand the scope, and then, foster a stronger relationship to that effect. Next slide, please. So the second thematic area was looking at regulation. And the recommendation was that the Ministry of Health to strengthen the scope and the mandate of the regulatory authorities and the agencies. Here, we need to develop our legislative instruments across board, so that we can encourage collaboration and agree on the scope and the way that we do our work. On that side, we're also looking at the opportunities for the resource mobilization. Like I mentioned, we used to have the private sector unit that is part currently of the domestic mobilization of the ministry. So again, the recommendation was to continuously kind of dialogue or private sector, and that's facilitated by the private sector alliance so that they can have a common voice, the formation of a federation, and then that's also include the self-financing private sector, especially as far as service delivery is concerned. The other one was related to the human resource opportunities for the staff of the private sector to be better engaged. For example, if you had someone who was going full-time private sector work, we need to open up for them to also develop their career. They also have the opportunity for promotion, similar to the way that is done in the public sector. Every facility is located within a certain district and also being supported and overseen by the district health administration, which is more a public institution. So year on year, when people are promoted, there can be that collaboration with the public and the private. That will give better option for people to even move full-time into private, concentrate their effort, and at any point in time when they want to come back into the public sector, they should be able to continue, their career path. I think that has been a bit of a challenge, making it a bit more difficult for people to, readily go full-time for the private sector, and it's one of the recommendations that we can also work towards. Next slide, please. The third one is looking at service delivery. The Ministry of Health to develop the measures to mitigate the private sector financial market conditions. The proposition was to make an upward review of the insurance tariffs because they needed the monies to pay their own staff in terms of the infrastructure, various medical products that they needed to get on board. They were also advocating for the opportunity for the ministry to second some of the staff to them, similar to the way that is done for the faith-based institutions. That will relieve them a bit of cost, and then also being exempted from some of the taxes on importation of medical products. And these were, areas that the private sector felt that if these are done, it will also help them to provide quality care to the. I think that Dr. Paddy would also expand a little bit on that. I don't want to say too much for him when he gets the platform. He's going to talk about some of those details here. And then finally, the Ministry of Health to support referral mechanisms between the public sector institutions and then also the private. Here, we are looking at liaising with the service delivery agencies to strengthen the referral policy implementation. The referral feedback systems are also quite important, and that is going to be monitored by the District Health Administration to ensure learning and compliance to referral policies. The referral policy provides for upward referral and also back referral. By and large, the upward referral works pretty well because they are referring from a lower facility to a higher facility. But when patients are stabilized and then they have to free the beds at the higher facilities, that back referral, the policy is there, it spells out clearly, but the implementation and its enforcement have been a bit of a challenge. Next slide, please. So on the reflections, I would hand over now to Dr. Paddy Aite, who will talk on the private sector reflections, and he would expand a little bit on some of the other areas that really affect the private sector and the specific recommendations that are going to come there. So on that note, Dr. Paddy Aite, representing the private sector, you are most welcome and to fire. Thank you. I think you can unmute and then.
All right, thank you very much, Dr. Asiedu, for a lovely presentation. It has been a pleasure working with you on this and the rest of the team on this project. My name is Dr. Paddy Aite. I'm an obstetrician gynecologist, and I'll be representing the private sector in today's meeting. So for the private sector, what does this engagement mean? It's important that we have an involvement of the private sector in every step of the process engagement. The Ministry of Health has got several plans. It was fascinating in the preparation of this study to read all the plans that the Ministry of Health had put in place over the years about things that they intended to do. Unfortunately, those plans were written without the engagement or the involvement of the private sector and were driven mainly in the public sector. So the proportion of our population, of our medical care that is provided by, that looks after maybe 30 to 50% of our population were not involved in the project. The end result is that targets were not necessarily met. We believe that if the private sector is involved along the process, beginning to end, to ensure that we would have one mind, one purpose, one target, and we shall all pull together in that direction to try and achieve our targets. There is a need to institutionalize stakeholder engagement that will regularly reach out to the private sector. It's not enough for us to have plans that we intend to do this or intend to do that, but we should have a mechanism that is put in place that is to execute that particular agenda, and that mechanism should be monitored so that at all times the engagement is continuous, it is fruitful, it's beneficial, and we are all working together to achieve our targets. There is a need for an enabling environment for the private sector to thrive and to deliver. This is a big deal. It's important that we have like standard operating procedures that runs through both the private and the public sector. That will ensure that we can all deliver the same standard of care, no matter where the client goes. In the private sector, we are more concerned about, we know the clients vote with their feet. So quality of care, being nice, all that kind of stuff, it's a bit more, we focus a bit more on that. However, we also have our own challenges on the other side, being able to afford to look after the various staffs that we have hired at various levels. And the result sometimes is that you have staff that have lower qualification, that are doing particular roles that wouldn't necessarily wouldn't be exactly the ideal situation. We believe that if we can have quality standards running all through, be it in the public or in the private sector, it would ensure that the clients can be provided with the right kind of care. We need to ensure that the staff supports, sometimes even with salaries, for people who are working in certain particular areas, would ensure that that standard is looked after or saying is achieved. One of our big headaches are, for example, duties at the port. We import things, and we don't have, in the private sector, we don't get the duty exemptions that the public sector gets. And therefore, if you look at the amount of money you have, and our duties are about 40%, you have to really think about, you end up buying lower quality equipment just to be able to afford it because of how much duty and things that you are going to pay. When we are able to address some of these concerns and ensuring that we can get better equipment at reasonable prices, which will generally result in a better environment for people to be able to make the necessary investments. There is certainly a need to revisit the financial incentives for the private sector and ensure that they are adequate. We are aware of the fact that in the private sector, they are either non-profits, cost recovery, or for profit. But the objective for all of them is to reduce the burden of disease that is on the population. And that burden of disease is an obligation that any government must try and deal with. And therefore, it is in the interest of government to assist all the players, be it those in the public or the private sector, to help deal with that social obligation. The cost of capital is very high. Unfortunately, you end up, healthcare is a long-term investment. It will take you 10 years or even more to recoup whatever investment you have. Our loans typically tend to be 5 years in this country. So if you are borrowing money, when the bank wants their money back in 5 years at a relatively high interest rate, it makes it difficult to invest in the kind of equipment that you would buy and let it lie down until an emergency occurs. So people tend not to invest in high capital intensive projects. And that's why we don't have, for example, a lot of intensive care units in this country, because it's expensive to set up and payments are a problem, costs are a problem. We need to have incentives for people to go into the deprived areas where our health services are inadequate. We need to look once again at our tax situation. I would think that if we can show that we have reinvested our revenues in additional equipment or in the business to ensure that we can render more services, it should be considered towards our tax obligation, because if we didn't do it, government has to do it. So they must meet us halfway somewhere along the line. We believe that insurance companies should pay adequate compensation for services rendered. Our tariffs tend to be more calculated based on a public sector market, where the public sector government takes care of a lot of the burden. The private sector, all the burdens are yours. And if attention is paid to that aspect to ensure that it becomes financially worthwhile to do the work that will be compensated for by the insurance companies, then it makes it worth a good prospect as an incentive to make that investment. And then we also need prompt payment of fees. It takes quite a long time for the insurance companies to pay, and the public health insurance even longer. That's capital that is locked up. Services you can't render, salaries you can't pay. Those are, just some aspects of the financial incentives that, if attention is paid to, would definitely make a big difference. We believe that the public and private sectors should be regulated by a common standard of requirements. Our regulators tend to forgive or are more kind or gentle to the public sector institutions and hold the private sector institutions to a higher standard, whilst we believe that we should all be held to a higher standard. And if we are held to that standard, our clients get a better service and we all benefit from it. And we also believe that our regulators should be streamlined, such that there's not only, we tend to have a bit of duplication. In other words, you go to one regulator, he asks for A, B, C, D, you go to the next regulator and would expect that the next regulator is building up on what you provided already, but he's also still asking, go and bring me A, B, C, and then add E, F, G to it. And if they're streamlined, it ensures that compliance becomes better. And it also ensures that monitoring and the rest should come better. Those are some of the views that we picked up from this study, from the private sector. And we are quite encouraged by the attention our Ministry of Health has placed on this, and the focus that they've placed on this, and the commitments that they are making to address these issues, so that we all pull together and carry this work and help our clients to get to the targets that we are hoping to achieve. That brings me to the end of my presentation. I shall hand over to Dr. Sego Moses to continue. Thank you very much for the opportunity.
Thank you very much, Paddy. So from where he left off, after the situation analysis and the stakeholder engagement and all the dialogues that went alongside, we together as stakeholders agreed on some broad next steps which we have been pursuing to date. Next slide, please. So first on the list is the need to harmonize the regulatory mechanisms that Dr. Aite spoke about. And that process has already begun with discussions with the Health Facilities Regulatory Authority, the National Health Insurance Authority, and other key stakeholders to ensure that we're using the same standards for public and private providers and ensuring that we are going along the same path. Leadership and ownership of the Ministry of Health was identified as key to make sure that the process is seen through and the implementation of agreed next steps is also seen through. And so far, we're happy that the Ministry of Health is in the driving seat. The Quality Management Unit of the Ministry and under the PPME division is in the seat. And so they are able to rally together all the key agencies of the Ministry of Health to ensure that this partnership is improved. And then we also said that there is a need for an independent facilitator to bring together the information and support the process. And this has also started. We all agree that it will take time to get things to the level that we need. And so we are, all stakeholders involved are committed to providing the time. And already we've started engaging better. We have the private sector represented on various committees that we've had in place. We've had their participation improved, and we are communicating better to address the gaps that we identified. We agreed to disseminate the strategy, and we've used some existing platforms already to disseminate, but we recognize the need to have a proper strategy so that this dissemination will not be piecemeal. And so that is being worked on to help us have a good roadmap to follow through. We have shared some of the findings already, and we have also shared what we have documented so far on the Quality of Care Network website. Next slide. Next slide, please. So this is a summary of the process we've gone through. And as you can see, this is a snapshot of the network website page that is dedicated to Ghana's information sharing. We've gone through, you can visit that site and see more in detail the research protocol, the literature review, the situation analysis report, and other bits of information that we hope will put the picture into better perspective for you. Thank you for your attention. And I now hand over to Rosalind and Bletta to take over. Thank you.
Thank you very much. Thank you to our distinguished panelists and presenters. We learned a lot about the process as well as the outcomes of this process. And now we would like to open to the session to questions and answers. So I'll first start from the questions, some of the questions that have been placed in the chat. Please start typing your questions in the chat or clarifications or comments that you may have. So the first question is from Pritha Biswas. And Pritha is asking, are there any health financing mechanisms to enable access to services provided by the private and faith-based organizations or facilities? And I think this question I would like to, most likely to ask to Dr. Ernest. So Dr. Ernest, there is a question in relation to financing mechanisms to enable access to health services by private providers.
You want me to take it now? Or we will?
Yes, let's take a few like that, and then we can start grouping. So far, there are a few questions, and then we have a group of questions. So I'll just go through the initial, and then we do a grouping. Thank you.
So thank you very much. I think this is one of the recommendations that came, especially what exists is that, for example, the tariffs for the private sector is totally different from the tariffs for the public sector for national health insurance. But beyond this, there is some requests that have come up. During the dialogue, it was obvious that we could, if we really want to let everybody within the country benefit quality care without any financial barrier at the point of use of service, as Ghana has defined a universal health coverage roadmap and our definition for the UHC, it means that we need to also support the private sector as they are. Again, the fact that private sector facilities, some of them are rural located and others are urban, urban facilities. And during the presentation, he clearly mentioned what the government could do, creating that enabling environment for the private sector to thrive and be able to provide quality care. So yes, there is opportunity for some financing mechanisms to be able to assess, services provided. So we will take this up again as we share this with the leadership of the ministry, engage the various stakeholders and agencies. There would be that opportunity for us to look into some of these things. Yeah, thank you very much.
Thank you very much. A second question is in relation to involvement of professional associations. So were the professional associations involved in the process? And perhaps you can make a broader, all the panelists can make a larger commentary regarding the stakeholders who were involved in this process and their role in the process.
So I'll take it first, and then I also open up for my colleagues. Even though Rosalind is one of the facilitators, yes, she also has some experience around the work that we did, and colleagues can also. Yes, we really had a wider stakeholder engagement. If you look at the areas that we were looking at, we looked at both the policy space and where the ministry came on board, and some of the public institution leadership also were on board. Then we came into the subnational levels. We engaged with some of the professional regulatory bodies and also the regulators themselves, to have a better understanding. And so it was really, I would say that the study had a wider scope to make sure that no one is left behind. During the process, along the line, together with our consultant who was doing the work, we continuously had local engagements, and ultimately during the multi-stakeholder dialogue, we brought on board wider stakeholders to sit together to have a conversation around what we were able to find. So in the event that any stakeholder, was probably left out and we identified that this is not cast in stone, these findings are, I would say, it's a living document. And so there are opportunities for us to even look again and see what good things that can be added. Especially, you will notice that out of the findings, we came up with some recommendations, and these recommendations are going to be living. So as and when we find situations where it requires us to adjust them, why not? These are opportunities for us to do that. Thank you very much.
Thank you very much, Dr. Asiedu. There is a broader question now in relation to accountability and inclusion of private sector data and quality indicators. The question, in fact, is how can we involve private sector to document quality indicators? And what is your opinion? Should this be mandated or optional? And perhaps this is a question for the whole panel, for both sides, for the public and private sector, as well as for the maternal and newborn section of the discussion.
I think I do not want to be so greedy and Dr. Isabella Sekou-Moses is around. Once we are entering into the space of, indicators, and then also, I think Dr. Isabella can take some. Rosalind, as I mentioned, I can see your chair going back and coming forward. You are a facilitator, but your mouth is not shut, so there may be opportunity for you to share some other things as well. Thank you.
All right, so let me take the first shot. Yes, we really aim at having all service providers to provide data on quality of care. So our DIMS, or the Health Information Management System, expects that private providers will link up to the data provision through their various districts. And so they are expected to make inputs and submit data to the districts to be compiled upwards. This works better in some places than others, but that is what we are aiming at, and we are working together towards this, to the extent that in order to ensure that they are fully accountable and submitting their data, one of the recommendations has been that the district office would actually confirm whether or not this data is forthcoming and provide evidence before the regulatory bodies re-register or renew registration of providers when they are due. And we have also been working with the regulators to input some data into their accreditation and credentialing tools, so that all facilities, both private and public, are measured on these indicators regularly. These are ways that by which we are working towards ensuring accountability. But as I said, there is room for improvement, and we are continuing to dialogue on this. And also, in this regard, when regions on a yearly basis, half-yearly basis, have their review meetings, both regions and districts, health management teams have their review meetings, private providers are invited. And we have seen regions showing a snapshot of what is being provided from which facilities, commending those private providers that are regularly updating their data and trying to encourage those who are not doing so to also improve. Thank you.
Thank you very much, Dr. Isabella. There is a question for Dr. Paddy. And Dr. Paddy, the question is, people would like to see what is the strategy or incentive to unify the sector, the private sector in Ghana. So it says that in many places, the private sector is highly individualized. So is there any strategy or is there any vision on how to bring this sector to speak with one voice or to articulate a position, a joint position? Over to you, Dr. Paddy.
Thank you. This is one of the things that the Ministry of Health is quite concerned about. It's one of the challenges that they faced even whilst we are conducting this study, because it appears as if we have got many different voices. I think it's one of the things that we have to definitely work on. Our societies were initially just a society of private and medical practitioners, but those are society of doctors and dentists. It's not really a society of the health institutions per se. And yet we've got health institutions that are not necessarily owned by doctors or dentists, but are either owned by other individuals. In other markets, you've got health institutions that are owned by hedge funds and things of that sort. So I think it's one of the things that we definitely have to work together to get whatever societies that currently exists, either health facilities, societies of doctors, the pharmacists, the pharmaceutical societies, we need to get them all together under the Ministry of Health to come together and form one kind of umbrella organization that allows the Ministry of Health to engage us all together. If we had one body where we had representatives of the various groupings under that, we'll be able to have one means by which we engage the Ministry of Health, and that body too needs to ensure that their members all fall into line. Secondly, if we can find a way that would incentivize these people to be members of the groupings. In other words, if you are part of this group, your engagement with government is better or easier. To encourage people to join these groups, but it also allows government to regulate them better because they are available and they are reachable. It is an ongoing process, which I believe over the next couple of months, we are going to drive it significantly more than in times past. And hopefully the next time we talk to you in a couple of months' time, we should be able to tell you that we've achieved that.
Thank you very much. Thank you, Dr. Pade. Rosalind, if you are connected, shall I hand over to you the second half of the questions?
Okay, thank you very much, Bleta. So there are a few more questions in the chat box. Peter wants to know that what would be your suggestion on how standalone self-financing setups, such as lab alone, ultrasound alone, not necessarily a hospital, how these facilities can be roped into the process of organizing the health sector. And then I just want to read a couple of them so you can take them together. Another person wants to know if the non-private sector has adequate human resource to assess the faith-based and private sector in Ghana. I think that was touched on a bit during the presentation, but Ernest, maybe you can take these two and then we can take the next set. Thank you.
Thank you very much, Rosalind. So yes, I've seen in the chat box the question from Peter, especially as far as the standalone institutions are concerned. I think just piggybacking on what Dr. Aite also talked about, clearly, yes, we can't leave anyone behind. So that also helps us to group all these institutions together, and that will give that opportunity for each of the institutions to play their role. For example, you talked about standalone ultrasound, standalone laboratory. People are referred from one facility to another. We are looking at one-stop shops, but their location are also very critical for people to have access as they also invest into these and to make sure that we get to that point where we need to get to. So I think there are opportunities for health facility regulatory agency playing their role and ensuring that we include some of the standards, like Dr. Isabella was saying. We've had conversations with them to make sure that these quality standards are inputted into those requirements that would help you to establish an institution, as well as also when you're coming to renew your license. Similarly, this is being done both for public and private, whether it's standalone or integrated within the institution. So I think that part of it, there shouldn't be any problems at all. Each one of them is being regulated to make sure that quality care is being provided on that. Thank you very much, Rosie.
Thank you, Ernest. There's another one on how the private sector can contribute to or be involved in the training of healthcare staff. So within the public sector, there may be a lot of capacity building activities. How are we involving the private sector in this, and how can that be improved?
Thank you very much. Again, I think the engagement, this whole dissemination is one very important part of what we have been doing in the past and continue to do. You recall that when I was making my presentation, I made mention of something which is very important, even the times that the private sector can be engaged. For example, when people enter a public institution that has enough resources to provide some kind of services, it might be the same for the private sector. The private sector is supposed to engage the services of human resource across board, and they are supposed to be all full-time staff in terms of their remuneration, and then also their in terms of payments and things like that. It becomes a bit of a challenge. So by and large, you will notice that a chunk of the staff who work in the private sector are also public sector staff who probably are doing their locums there. And so the timing for capacity building in itself has to be reviewed if we really want the private sector to benefit from this. And during the multi-stakeholder engagement. And during the study, some of these things became obvious. We have most of our trainings during the day. And this is the same time that the private person is seeing the patients, and the staff, whether they are permanent or they are doing locum, are really discharging their services at that particular time. And so we made a lot of efforts to also even inviting the private sector. It might not be that favorable for them. If we really want to get the private sector on board, then it means that we may have to vary even the timing of those capacity building sessions. So we have taken that into consideration. In many of the districts, the district directorates work closely with the private sector, and that is where we want to have that win-win situation. We've come to also another situation where we've even found out that in some of the districts, especially in some urban areas, there is no existence of a public institution there. And the district director works very closely with the private institutions to make sure that even the data, and as far as quality care is concerned, is being collected only from the private sector. Wherever the director gets any form of resources in terms of capacity building, training, and things like that, they are all channeled to the private sector. And they are also mindful of the fact that you need to adapt and tailor, those capacity building, especially as far as the timing is concerned, so that they can also equally work closely.
Thank you very much, Dr. Asiedu. Thank you very much, Dr. Paddy. Thank you very much, Dr. Isabella. As we are coming to the close of the session, we have only one question for all of you, but a very short one. If you have to advise the other countries to embark in the same process, what would be your advice? What is one thing that they must do?
I think I'll open up for my colleagues to make their contributions first, and then I'll say a few words. Otherwise, I'm monopolizing the platform. So Dr. Isabella, please.
All right. So I'll tell them that this is a very useful process. And as they embark on it, they should make sure that the key stakeholders are right there from the beginning, from the planning through the data analysis. They should be involved. No one stakeholder, should lead. They should be involved together. And the overarching body, that's the Ministry of Health, should be there charting the course and coordinating the whole effort. Thank you.
Well, I would say that there should be a national a national commitment and a political will to achieve this objective. And it should be one of the things that they should set timelines for and really drive it and get all the people involved to get to achieve the objective. It shouldn't just be a discussion or a talk shop, but they must really have that. They must put in the necessary commitment to get it done in a timely manner. Thank you.
Thank you very much. So from our side, as far as the ministry is concerned, we would encourage our colleagues in other countries to make sure that, yes, these engagements are done appropriately. We would also advise that, especially for the private sector, based on the experience we have, as the fragmentations make it a bit difficult for the ministry to engage one body as far as their governance systems are concerned. So that the various governments from the various countries to support their own private sector to come together as one body so that their ministries can engage them appropriately and look at those specifics, those specific challenges that specific private entities face and support them at that top governance level for them to do these things into themselves. So I think this is what we will do. Thank you.
Thank you very much. Really appreciate it. This is the first webinar on the series of 3, which will be followed by Nigeria and Bangladesh soon. As I said in the beginning, I'll repeat, very important for us in WHO, but also for all the countries, especially those countries in the network that will continue to embark in a similar process. So thank you to the Ghana team, and over to my colleague, Olive Kokoman.
Thank you, Berta. Thank you to the speakers and the participants today for sharing these valuable learnings and insights. This was really excellent. We will be sharing the recording and the presentation, both by email to all the participants as well as on our website. So stay engaged. Information on this project, as Berta said, there'll be 2 upcoming webinars, one on Bangladesh and Nigeria. there will also be the documentation and the learning shared on our website. So please stay engaged with us. Thank you again, and have a lovely day.
Thank Rosie.
Thank you so much, Ernest. It's great.
Thank you.
Thank you. Thank you.